Good afternoon, ladies and gentlemen. We are pleased to welcome you to our afternoon session on palliative care. Speaking today will be Lynda Fields. She's an assistant professor at Marian University. She received her MSN from Marian University and then obtained her board certification as an advanced practice nurse prescriber. She has developed a hospice in a rural community and led it to Joint Commission accreditation. She also developed the Sister Mary Agreda Touche Palliative Care Certificate for Registered Nurse through the School of Nursing, Marian University. She's a nurse practitioner at the Comprehensive Pain Management in Fox Valley, and her experience as an RN includes care of patients and families in oncology, cardiac, general medical unit, and also in the home care setting. We're also pleased to have with us today Dr. Justin Clutter, who graduated from Indiana University Medical School in 2000 and finished his residency in family practice in Terre Haute, Indiana, and was faculty at the Union Hospital Family Medicine Residency Training Program. In 2004, he began working in the hospice field as a medical director for Vitalism, which is then the third largest for-profit hospital in the nation. He has been board certified as a specialist in hospice and palliative medicine since 2007. Early in 2008, he made the transition to full-time palliative medicine and took a position at Hospice of the Bluegrass, one of the leading hospice and palliative care programs in the country in Lexington, Kentucky. In 2009, he moved to Fond du Lac to become Agnesian Hospice Hope's first-time, full-time medical director, and has led Agnesian HealthCare in their efforts to build a palliative care program. We're very pleased and fortunate to have Dr. Clutter speak to us today about palliative care. Dr. Clutter.
Thanks. Can everybody hear me in the back? Can you go up or down? Good? Okay. All right. I'm going to talk a little bit about palliative care today. This is a new topic for a lot of people. It's been in the news lately. In the last couple of years, we've had to talk about death panels, and palliative care has gone from something that politicians are very interested in to, with the death panel talk, actually in Washington it was described as toxic, and nobody wanted to touch it. Nobody wanted to talk about palliative care because they were worried about losing votes. So palliative care has kind of been up and down. It's recently in the news, but it's actually an old idea. And we're going to talk about three things related to palliative care today. What it is, where did it come from, and why do we need it? To start off with, I'm going to start talking about something that doctors really do our best to try to avoid talking about, and that's death. We're going to start by looking at death in the last 100, 120 years or so. If you look at how people died throughout most of history, things really hadn't changed much from as far back as we can remember through 1900 or so. If you looked at death in 1900, we've got pretty good records. States are keeping record at this point. There's some national data. But basically, there's three primary causes of death. So when people died at the turn of last century, it was typically from infection, from trauma, from childbirth. And this kind of makes sense. There were no antibiotics. Somebody was pretty healthy. They're getting up there in years. They get a pneumonia. They have a little bit of a cough. It's really not a big deal. They get sicker and sicker, start running a fever, gets into their lungs. They can't breathe, call the doctor. There's really not anything to do. They die shortly thereafter. So in a period of a very short time, maybe a week, they've gone from relatively healthy to they're gone. Same thing with trauma. Somebody working on a farm gets hurt. There's no surgery. There's no hospitals. There's really nothing to do. They die suddenly. So we have this type of death that comes very suddenly to people, but it's also a family affair. When someone, for instance, has a farm accident, you bring them into the house, you call the doctor comes over, looks at them, sorry, we really can't do anything, maybe they'll get better, maybe they won't. The family all comes around. Same thing with pneumonia. When someone was dying, family members, friends, the community kind of rallied around, and there were people there supporting the patient in their home. It was also a spiritual event. This time, the doctor may come out, made house calls, came to the patient's home and may tell the family there's really nothing more we can do. It's time to call the priest, time to call the pastor. Things were handed over to clergy. Clergy were involved in serious illnesses and death. Then if you look what happened mid-century, and a lot of people say, well, this is the antibiotic era. And that's true, but there were other changes that were happening too. But prior to 1900, people were starting to play around with various anesthetic agents. By the 1920s into the 1940s and 50s, more modern anesthetic agents come about. So now anesthesia is a specialty, and anesthesiologists can actually put people to sleep to allow surgeons to do very elaborate surgeries. So we start seeing not only antibiotics, but we start seeing surgical technique advance. We also have the technology revolution with all sorts of electronic gizmos and gadgets starting out. So now we can monitor things. We can put numbers onto how people are doing. We can, blood pressure monitoring starts being developed. ICUs start being developed. We start developing ventilators during this time period. And basically the mindset started to change. This first quote is from 1925. This is a quote from England. It's anonymous as far as I can tell, the source I got it from. And this kind of summed up how a lot of people were starting to look at medicine at the time. If only patients could leave their damaged physical vessels at the hospital for repair while taking their social and emotional selves home. And I get a lot of chuckles when I use this quote in talks to medical people because we all sit here and say, oh, that's horrible. There's still a little bit of that in medicine today. There was a lot more when technology was really taking off. But unfortunately, doctors were becoming more and more focused on the physical, and it was less and less of a person we were treating and more of a disease or an organ. We started seeing the medical specialties develop, and cardiologists treat hearts. GI doctors treat intestine, stomach, liver. And we kind of lose that this was a person here. And then this man is Nye Bevan. He was I believe it was a Minister of Health in England that was either responsible for or extremely influential in England adopting their National Health Service. And he's got a rather interesting quote. He said, "I would rather be kept alive in the efficient, if cold, altruism of a large hospital than expire in a gush of warm sympathy in a small one." So basically we see the idea developing small hospitals where there's not technology, where there's not the latest and greatest. I don't want to be there. I want to go to a big hospital. I want to be kept alive. And we started seeing what some people have called vitalism. Basically the idea that life at all costs, save life, biologic life. And again, we kind of lose that this is a person, this is a whole person, focus on the body. So, with all this great technology, with all these advances, things should be getting better, right? That's what Nye Bevan was saying, that's what that other quote was, we do great things to the body. Well, in 1952, a study in England showed that people dying in England died in really appalling conditions at home. Death was not a good experience. People had a lot of suffering and a lot of pain. It was a bad experience for most people. 1960, charitable homes, which basically these are kind of the precursors of today's nursing homes, you can think of it that way. Charitable homes in England were found to have horrible conditions, often outright neglect. And then in 1963, they looked at the university hospital. If there's anywhere that should provide good care and meet patients' needs, it ought to be a university teaching hospital. And what they found that a lot of suffering was left untreated even in those institutions. So basically what we had done was we had taken these rather rapid methods of dying and replaced them with alphabet soup. This probably means nothing to you guys, but basically this is coronary artery disease, so heart attacks and arteries getting clogged up. Congestive heart failure, often caused by heart attacks or other vascular disease. Strokes, the CVA, and cancer. And basically the difference you see is these are not rapid killers. Somebody 50 years before got a pneumonia and within a week they'd gone from healthy to dead. Now they have a heart attack. Now they're left crippled for 5, 10, 15, 20 years. They may be alive, but they have a hard time getting out of their home. They have such bad heart failure they get winded just walking out to the mailbox. Patients with strokes, maybe very even worse. They had a stroke, they don't die, but they're left in a very incapacitated state. And so now we have to have somewhere to put these patients. So we develop nursing homes. Unfortunately, what happens is these diseases are isolating. People no longer can take part in their normal culture. Their lives change. They're in an institution or they're homebound. People that are dying of diseases, especially at this time, spent long periods of time in the hospital. It wasn't uncommon to spend weeks in the ICU. Sometimes some patients spent months in the ICU in this time period. Definitely patients spent months in the hospital. So the hospital's not your home, your family's not there, there's visiting hours, kids can't come visit. It's a very isolating system we've created in the middle of last century. And then the other interesting fact was that with all this technology surrounding patients, death had become very medical and not mystical. Whereas at the turn of the century, death was the passage from this life to what lays beyond it. Suddenly, by mid-century, death is when your heart stops, but not just when your heart stops. When your heart stops and a doctor can't get it going again. And that was a pretty significant shift. It's no longer about anything mystical. It's not spiritual. It's not a social event. It's now death is a biologic event. So in the middle of all this, there was a Methodist theologian named Paul Ramsey, and he was at Princeton. And he had a very novel idea. He thought this was a problem developing, but nobody had really talked about it. It hadn't really been brought to light at the university hospital. And he kind of had this novel approach. You can think about it like this. The first Gulf War gave us the embedded reporter, where reporters actually lived with the troops, ate what the troops ate, went where the troops went, saw what the troops saw, and reported on it. Well, Paul Ramsey basically was an embedded theologian. He got permission to go to the university hospital, I think a couple university hospitals where he was, and basically just hung out on the wards. He sat there in the ICU, he sat there on the medical floors, and he watched what happened. He watched how the doctors treated patients, he watched how doctors and nurses and residents and medical students interacted, he watched how they interacted with the patient. And he found some very revealing things out about how our medical system had changed. And he published these as a book called The Patient as Person, after he gave them as a presentation at Yale University. One of the quotes from that book is, "The patient has entered a covenant with the physician for his complete care, not for continuing useless efforts to cure. It's another sort of negligence to treat the dying." Now this is not maybe dying, this is patients who are dying, as if they're going to get well or might get well. The right medical treatment, the right medical practice will provide those who may get well with the assistance they need. So obviously, he's saying if someone may get well, they need treatment to try to make them well. But if they're dying, they provide those who are dying with care and assistance they need in their final passage. And the treatment for that, for those patients who are dying, is care. It's not struggle. So we've got Paul Ramsey in the 1960s giving this lecture, this book being published. But if we back up just a little bit, this is kind of where the philosophy of palliative care is coming from in this country. Others like Kubler-Ross were very instrumental in it. But palliative care and hospice actually, we typically say it started in England. And in 1948, Cicely Saunders got her nursing degree and began nursing. And Cicely Saunders had a particular interest in caring for patients who were very, very sick and were dying, partly because not a lot of the people were interested in those patients. They were somewhat neglected. Again, medicine's focused on cure and fixing things and the physical. She was a very religious, very spiritual person. And then in the 1950s, she went back and went to medical school and became a physician. She spent the 1960s doing research at St. Joseph's Hospice in England and did a lot of groundbreaking research, really did a lot of research that is what a lot of our current research on pain medicine and treatment of pain, especially in dying patients, is based on. Then in 1967, she and a couple others started St. Christopher's Hospice, and this was considered the first modern hospice. And this is really where palliative care sort of takes off in history. St. Christopher's Hospice had three missions. The first was to take very good care of dying patients. This is not a segment of the population that hospitals are really wanting to take care of at this point. These patients we can't fix. Hospitals and doctors, middle of last century, about fixing things. These people really didn't have a good place to go to get good treatment. The second goal was research. She didn't want to just be a place where you could put these people, just a roof over dying patients' heads so they didn't get rained on. She actually wanted it to be somewhere they could get good, top-quality care. But how would you know what good, top-quality care is unless you do research and learn and try to develop the field? So there's a big research emphasis at St. Christopher's Hospice. And the third goal of St. Christopher's Hospice was actually education. They wanted to provide a good place for patients to receive care. They wanted to learn how to take care of patients better. And they also wanted to share what they learned with other people. And in fact, people from all over the world went to St. Christopher's Hospice to learn how Cicely Saunders and her group was doing palliative care. And actually, a couple people from the St. Agnes, what is now the St. Agnes Hospice here, when they were starting the hospice, actually went to England and spent some time there learning from this group at St. Christopher's. And Cicely Saunders said this, and we'll talk about her ideas here in just a second. She said, first, we have to make as careful assessment as possible of the symptoms that trouble the patient. This is not to make a diagnosis or give specific treatment. Now, these are patients that have already been diagnosed. They have bad diseases. She's not saying diagnose them further. She's saying that's been done, but it's in order to treat pain and all the other things that can add up to a state of misery as a disease itself. And this was very important. This was perhaps the first time somebody really looked at suffering, misery, as something that was a byproduct of the disease. Up until that point, people just assumed if you have this particular disease, you're going to have pain, you're going to have this symptom, you're going to have that symptom. That's just the way it is. Cicely Saunders said, no, we need to look into this. We need to find the cause of the suffering, the cause of the pain, the cause of the distress, and see if we can't treat it just like we treat a disease. This led her to come up with the idea that she called total pain, that is one of the fundamental parts of palliative care. Basically, her idea of total pain was that there's 4 domains of suffering. You can suffer physically, you can suffer emotionally, socially, and spiritually. So for instance, you have a cancer, and the tumor is pushing on something. Obviously, whatever the cancer is pushing on is going to hurt. So there's physical pain. But just the fact that you've just been told you have cancer, that's emotionally very disturbing. So there's emotional pain that people suffer. That changes your social dynamic. Maybe you were the breadwinner in your family, and you can no longer work because of this disease. So now you have social distress. You may never live to see your child graduate from college. So that's social distress, which adds to emotional distress. Then there's a spiritual distress. You get told you have cancer. Patients walk out of the doctor's office and very frequently ask, why me? Did I do something? Why? All my friends, they may have worse health habits than I do, and I'm the one with cancer? I'm the one that's going to die prematurely? So all of these things together basically add up to total pain. And Cicely Saunders' big point was, you can treat the physical pain, which is what doctors focus in on, and that's about as much as they did at the time. If doctors did deal with patients in their lives, was treat the physical pain. But if you treat the physical pain, and you take it out of the equation, the patient still has a lot of reasons that they're suffering. So you really haven't reduced or relieved the patient's suffering. And I'll actually tell you, in fact, that as a physician, my part of palliative care, my little niche, is the physical side. That's what I'm trained to do. I'm a physician. So I can treat pain, but if I have a patient who's got very severe emotional and social distress situation is just causing them a lot of suffering, it's very hard to treat that pain. At the presentation a month or 2 ago, I had one of the people in the audience ask me, how often can you treat pain so that the person's out of pain? How often can you actually treat pain? Is there 80% of the time you can treat pain, 100% of the time, 50% of the time? And my answer came back to this. Physical pain, most of the time. But most of the time, it's not just physical pain. And if a person has emotional pain that's not being dealt with, I'll probably never get their physical pain under control. They have social issues that aren't being addressed. I'll keep titrating their morphine. They'll have a little bit of pain relief, but often those patients will end up unconscious, sedated, before they actually say they're comfortable. And it's because everything ties together. Back to Cicely Saunders' idea of total pain. So if total pain is what we have to deal with, we need to come up with some way to do it. That's what palliative care's purpose is, in a sense. And this is a definition of palliative care from the American Academy of Hospice and Palliative Medicine. I pulled it off their website about 5 years ago. I checked it last week. Still the same. Basically, they say the goal of palliative care is to prevent and relieve suffering. And it's not pain, right? So the suffering ties right back into Cicely Saunders' idea of total pain. Suffering is not just physical pain, it's the whole picture. It's the emotional, the social, the spiritual needs, as well as the physical. And to support the best possible quality of life for patients and their families. And notice it's not just the patient. Families are right in the definition of palliative care. If you just treat the patient, you're missing that social part. Patients are connected to their families and friends, and if you don't work that into your care plan, you're probably not going to be successful in relieving the suffering. So regardless of the stage of the disease or the need for other therapies. And this is a little bit in contrast with hospice, and we'll talk about that in a minute. This isn't because hospice doesn't want this. This is because hospice is limited by the Medicare hospice benefit, which actually defines what hospice care is in our country. It's very different in Canada. Hospice is completely different in Canada. There's not this 6-month rule that we talk about with hospice in this country. And I think this next part of the definition, and this definition is several pages long, so I just took the top part of it. But this next part I think is really the key to what palliative care is. Palliative care is both a philosophy of care, and that's what we talked about up here. That's the relief of suffering. But it's also a highly structured system for delivering care. So we talked about the philosophy. That's Cicely Saunders' total pain. That's this idea that the patient is bigger than just their physical symptoms. But the highly structured system of delivering care is a part of the definition. And if you basically just have the philosophy, you really don't have what most of us in this field would consider palliative care. You've got the philosophy, and that's great. That's a good start. But palliative care is the way we work to intervene and try to work on these symptoms. And basically, that highly structured system of this palliative care is what we call the interdisciplinary team. And from Cicely Saunders' time forward, basically everybody who's researched in this field and looked at it has found and said that the interdisciplinary team is the best structure to address total claim. Now, interdisciplinary team basically means you've just got different professionals, all with different abilities, trying to assess the patient and meet their needs. So basically, I'm a physician. I'm trained and qualified to look at the physical aspects of a patient. Look at pain, diagnose pain, what's the pain coming from, what's the best treatment for the pain, monitor that treatment, and adjust that treatment. That's what I'm trained to do. But different disciplines are qualified to assess and address the different core elements. I really didn't have any training in emotional pain. I don't have formal training in how to address spiritual issues a patient may be faced with. And I don't have the training or the expertise on the social aspect of what a patient's dealing with. So if it rests just on one discipline, you're very limited in your ability to actually relieve the patient's suffering. So we need to pull all these different disciplines together. It basically works like this. Over there on the right, these are our 4 domains of suffering. And here's our team. Basically what palliative care is, it's a team. It's that multidisciplinary team. So you've got clergy, you've got social workers, you've got counselors, providers, and nurses. And each of us has our own skill set. So what each of us does as an individual is we look at each of these areas. So I'm a physician, but I'm also going to, when I talk to the patient, I'm going to be aware that there's spiritual, emotional, social issues as well as the physical that I'm keying in on. And I'm just going to take note of those. And I'm going to try to see how those interact with the physical. But I'm a physician, so I'm really, I know going in I'm not an expert at those areas. So I'm really going to focus in on the physical. And each one of these other providers does the same thing. For example, clergy are really going to focus in on the spiritual, but they're also going to look at all these other issues, all these other domains. And they're going to take the information, bring it back. So I take my assessment and I bring it back. And then basically as a team we communicate. Each team member gives their input to how this patient is doing, what's going on, how might this patient be suffering, how do these things all play together. And then as a team, we basically make a plan as a team and then implement that care plan for the patient. For example, I may go see a patient and they look like they're in horrible pain, so I say, I need to turn this patient's morphine up. This patient needs their morphine at least doubled. I imagine I'm probably going to have to double it maybe twice, maybe even 3 times. And I've had lots of experience with morphine, so you get to the point where you can just kind of tell, I think this person's going to need this much based on how they're doing right now. But then if the chaplain comes back and says, you know, this person opened up to me that there's some issues that went on in their past that they have a lot of guilt about, and that's really just tearing them up. I have to listen to that. Because if I just crank the morphine up, this patient may become sedated, may not be able to work through those spiritual issues that they need to, that's causing them distress. And then if we just keep that morphine high to try to keep this patient appearing comfortable, they never have the chance to, for instance, make amends with a family member that they're feeling this guilt over. So what we may do is we may talk with the chaplain and say, okay, well, this patient's experiencing a lot of pain. That makes sense. Let's go ahead and the chaplain will work on those spiritual issues with the patient. Try to work through some of those. I'm going to still use a little bit of pain medicine to try to take the edge off it. It's going to be hard for this person to really have a good conversation with the chaplain if they're writhing in pain. So we kind of work together. Then maybe when the spiritual needs are dealt with a bit more, maybe we don't need as much morphine. Maybe we need to turn the morphine up. But it's amazing how when you deal with all these issues together like that, the patient's more comfortable, often with less intervention from all of us. If the chaplain just tried to go in there and work through those spiritual issues without any pain medicine, that patient's hurting. They don't want to talk. Come back later. I don't feel good today. So it's all of us working together. That's how we provide palliative care. Then the question, why do we need it? Well, hopefully in palliative care, I kind of think this is a no-brainer. But if you look at how we provide care today, this is kind of a model that we at Palliative Care use to kind of explain why we think this approach is important. Basically, this is sort of a graph as you move toward your death over here. This is sort of like time. Now, as somebody gets sick, maybe they have cancer, maybe they get treatment, then they get better, they'd almost move back this way. Okay, so this is not a straight linear, you have to go step by step across. But you're diagnosed, and from that point forward, this is 100% of your care up here. 100% of your care, all the way till you're deemed terminal, is restorative care. We do everything. And when you're terminal is often when the doctor says there's nothing more to do. And I always warn patients, how long do you think it will take us to do everything that we can do for you? Unfortunately, as a doctor, having experience as a doctor, I tell patients you will run out of money or you will die before we have done everything. There's new tests coming out every day. We have all sorts of new scans. We have all sorts of lab tests we can do. We can always repeat things that were done 2 weeks ago because maybe it's changed. We can do everything for a really long time. We really hardly ever actually get everything done. But then once we tell a patient there's nothing more to do, because there's nothing more to do, essentially we just watch. If there was something more to do, we'd be back here doing it. So suddenly we've gone from doing everything to nothing more to do. The patient's often told, you're now palliative, or you're now on palliative treatment, which those of us in palliative care hate saying it that way. But then, because there's nothing more to do, we just watch. Patient gets a bigger room. Patient just sits there. They may get pain medicine as often as they want. Nobody really bothers to assess too much. If the patient wants it, give it to them. And we just kind of wait and watch. The doctors don't really come around as much anymore because, again, there's nothing more to do. And if there's nothing to do, why go in there? We just wait. And then, at some point, the person dies. And then, all of a sudden, we turn around to the family and say, well, Mrs. Smith, your husband just died. How are you going to cope? Let's talk about how you're going to cope. And remember, palliative care is also about the family. So let's look at what the family goes through. The family's doing everything. And doctors wouldn't be doing things unless it was going to work, right? I mean, that's just what people think. Unfortunately, that's not right. So we're doing everything. The family is just seeing us do everything. We're hopeful. We hope it works. We hope it works. We hope we can restore this patient's health. And then suddenly, in an instant, we're out of things to do, so we're doing nothing. And then suddenly, in another instance, my family member's gone. And it's a transition that just really throws families for a loop. Those of you who've had loved ones that have died in the hospital, you may be able to relate to this. You think the person's doing okay, and then all of a sudden the doctors come in and they say, all right, it's time to take the ventilator off because they're dying. People tend to think, when did this happen? Where we were doing everything, what happened? It's very unsettling for patients. Just the same as when they suddenly die. I think this is part of why a lot of patients' families kind of walk around and say, I can't believe it. I can't believe they're gone. It's not real. Because we jerked them from one of these phases to the next. Unfortunately, that's not the worst of it. The worst of it is, this is what I often see. Remember, there's so much to do that we pretty much never run out of things to do. So this whole palliative treatment, we often push to the very end. Where I was in Kentucky, Hospice of Bluegrass runs one of the larger, older palliative care programs in the country, and I was sort of running the hospital palliative care service. Spent most of my time in the intensive care unit. And literally there were countless patients that the day before the patient's family thought they were getting better. They were planning on leaving the hospital. That morning, the doctor comes in, says it doesn't look good. By that afternoon, the patient was dead. Patients' families have to go through this in such a rapid series of events, in such a short time frame, that they're just battered and kind of beat every which way. So what would palliative care, my field, like? How would we like to see this change? We've got this multidisciplinary model. How would we implement this? Well, this is another model from American Academy of Hospice Palliative Medicine. And basically, what we would like to see happen in the medical field is that at diagnosis of something bad, let's just say cancer, as you move toward death, as you get sicker, perhaps less restorative treatment is warranted. As you get down here right before death, it's obvious the treatment isn't working. If it was, you would be moving back this way. So as you progress, many patients, if they really understood what was going on, if they really had choices, would probably, as they approach death, spend less of the resources, less of their time trying to grasp that cure, trying to get better when it wasn't going to happen, and spend a little bit more time focusing on palliative treatments, relief of suffering. This is what Paul Ramsey was saying when he's saying those patients are dying, they need care. They need an emphasis here, not so much on curative treatment. And so it's a blend, it's a balance. It's not a line. You start the conversation right from the beginning. What can we do to keep you comfortable? As things look worse and worse, things aren't progressing well. We still keep doing aggressive things, but we really make sure that what we're doing is reasonable. It's really what the patient wants. In palliative care, there's sort of one of our mantras is treatments have to conform to. Interesting. They warned me that could happen. Treatments need to conform to the goals of the individual. And every patient's unique, so every patient has different goals. And so patients with similar disease may have very different care plans. So for instance, one patient may have that graph that looks like this. It doesn't always have to be that split. Okay? It's not a 50-50 split like that. It can be this. This is perfectly fine. This may be a patient who's, for example, I had a 27-year-old patient who had cervical cancer, who had young preteen and teenage kids. And she basically said, I know the chemotherapy makes me feel awful. I know it's not going to extend my life. I know I probably would feel physically better if I was on hospice, but I can't look at my kids and know that I declined chemo. I have to take it. I don't want this palliative care stuff. I want to keep seeing the oncologist. I want to keep taking chemo. Even if I die the day I take chemo, that's what I need to do. If I don't do that, it's going to tear me up. And I talked to her quite a bit, and I think she was right. She just was not going to be able to look her kids in the eye and not think that she had fought 110%. So for that patient, this is a palliative treatment plan. This is an appropriate treatment plan. Now another patient may have the same disease, maybe in a different state. Maybe this is an 80-some-year-old with cancer who says, you know what, I had a good life, and I don't care if this is treatable. I really don't care. I've had 3 relatives die of breast cancer. I've seen what they go through with chemo. I don't care if you tell me I could have 10 more years. I don't want it. I want to focus on comfort. And notice this is palliative treatment, not palliative care, okay? Because I would tell you palliative care, this is just as much palliative care if we work with this patient and find out this is really what they need to meet their emotional, social needs as this treatment. But these are both this similar disease, maybe even the same chance of survival, but very different treatment plans. And that's okay, again, because palliative care is all about the individual and those individual goals. So this is where palliative care would like to see this idea go with this multidisciplinary team, where we're working with patients earlier in the course of the illness, working with patients as they get sicker and sicker. And then hospice is kind of out there too. We've mentioned that a little bit earlier. If you look at what traditional medical care is, this is that curative care, this is that good medical care. I'm crazy. This is that good medical care. You have hospice. And hospice, I'll show you in a minute with the next circle that pops on here. Hospice is a form of palliative care. Hospice is the ideas of palliative care. Hospice grew out of the hospice movement in Europe, which is a little more palliative care than we are here. The split in the U.S. is palliative care is this idea without the constraints of the hospice Medicare guidelines, which impose the 6 months, the curative treatment is not for hospice, all that kind of business. But basically, if you look at what hospice does, there's a chunk of what hospice does that really is just good medical care. Oncologists treat their patients' pain, nausea, anxiety. That's just good medical care. Dying patients should be able to get pain medicine from their doctors without having to be on hospice, if you ask all of us in the hospice field. Now, hospice adds all of these social, emotional, spiritual support beyond what traditional Medicare or medical care does. But there's still this chunk that traditional medical care and hospice overlap. If you look at what hospice is defined by the Medicare hospice benefit. It's care for patients in the last stages of their life, and our government Medicare basically has said it's for patients in the last 6 months. So if your life expectancy is not 6 months or less, you aren't eligible for hospice. And that's a very artificial structure that's imposed on the palliative care field in our country that really those of us in hospice wish would just go away, but that's the structure we live in. And Medicare also says you have to be focused on care and not not doing the life-prolonging measures. For example, chemotherapy, life-prolonging measures aren't something that the government wants to pay for while they're also paying for hospice care. And again, it's all about the hospice Medicare benefit. It's the payment structure that imposes these rules on hospices. But there's a lot of people that get hospice. About 1 to 1.5 million receive hospice care. And I would tell you, hospice is actually a form of palliative care. It's the predominant form. Unfortunately, right now, it's all that we have that's reimbursable. All this other idea, all this multidisciplinary team, it's not reimbursed under the current structure, but hospice is. So if you really look at it, palliative care, as a philosophy, is pretty big. Again, there's a good chunk of traditional medical care. There's a big chunk of traditional medical care that overlaps with palliative care. What I do, giving morphine to patients, giving nausea medicine, working through physical symptoms, is just part of good medical care. There's a part of hospice and palliative care that overlap. But there's also palliative care that's outside of hospice. This would be the social support, the emotional support, all of this multidisciplinary approach. But these might be patients who have 2 or 3 years left. So a lot of people think we need to have palliative care, we need to have hospice, and they're very separate. The reality is palliative care is more of a philosophy. Hospice follows this model that I talked about, this interdisciplinary team. That's how hospice works. And so we already have a big chunk of palliative care now. What palliative care, when we talk about it in the non-hospice sense, is basically intending to do, it's taking those ideas that hospice has taken and just extending them past the Medicare requirements for 6 months, no aggressive treatment, and try to take this idea that I've been talking about here and extend it out further in the disease so that people earlier toward diagnosis can get this kind of care, so that we can move toward that graph where early on in the diagnosis we start blending the cure approach and also the palliative care, the person-centered approach, so that we kind of create a blend, and as the patient moves through their serious illness, they can kind of pick, do I want to focus more on aggressive care? Do I want to kind of swing a little more toward palliative care? And it really becomes the patient's choice how they would like to progress through their illness and what type of care and support they'd like. So I'm going to leave you with another quote from Paul Ramsey. He says, "In caring for the dying, we cease doing what was once called for and begin to do what is called for now." Again, caring. Really big emphasis on caring in palliative care. To care, to comfort, to be humanly present with the dying. Questions at the end? Why don't we run with that and then go ahead and cover it? Do you want? Okay. We can go ahead with questions.
We do have microphones, so if you wish to have a question, please raise your hand and we'll get a microphone to you. Anybody with questions? Okay. Pat's got the upper chair, I have the lower chair.
Once the patient gets to the point of palliative care or the death watching stage, and the doctor says that there's nothing left to do, and the family then sue the doctors claiming that they were negligent in meeting the needs of the patient.
Basically, in order to sue a patient in court, several things have to be proven against the doctor. The first is that the doctor had a duty to the patient. In this case, the doctor would have that duty. They would have a professional duty. The second thing you need to prove is that harm was caused to the patient. And that's where it gets a little bit trickier, because defining the harm that was done to the patient, it would kind of depend on how the patient's family would spin that. If they said, well, they were harmed by having medical treatments performed that caused them to suffer, that's a hard thing for juries to really wrap their minds around. And the defense would be, we weren't intending to harm them at all. We were intending the good, not the harm. So right there, it sort of gets sticky. So generally, it doesn't go any further than that step. The next step that actually has to be proven, not only that there's harm, that the doctor's actions directly cause the harm. If the doctor's actions are proven to follow what we call standard of care, and that is the doctor is doing things the way that accepted medical practice recommends they be done, following national guidelines, etc., the doctor wasn't out of line, then the doctor's actions may have caused some harm as a byproduct in that the patient suffered because they were going through all these needless treatments, but the doctor's action didn't directly cause the harm. So I've never heard of a case that has been taken to court with that approach. If a doctor does a treatment to a patient that the patient did not want, it's usually not a civil issue. It could be, but typically what happens is it's considered battery. So for instance, if I come in and do a blood test to you and you say, no, I don't give you consent to do blood tests, and I do it anyway, it's a criminal issue, it's battery. And most prosecutors won't push that. So for instance, when a patient's on a ventilator and the doctor doesn't want to take them off the ventilator, usually the worst the doctor faces is the possibility of the prosecutor pressing charges for battery. Now, if a doctor doesn't put a patient on the ventilator, the doctor's worried he's going to be sued for wrongful loss of life. So doctors see it as much less dangerous to do too much than too little. Doing too little is that's the biggest thing that gets us as doctors sued. And so, again, we're trained to do everything. We're worried about lawyers if we don't do everything. We really don't worry too much about lawyers if we do too much. That's not one that we're worried is going to come back to hurt us. Does that answer your question?
Yes, thank you.
Okay.
Next question.
I have a couple of questions after Claire. The first one deals with the whole idea of our cultural understanding of death and how it connects with this thing called illness. When does illness indicate that we are really moving towards quote, terminal death, or we're not? And I'd like you to talk a little bit about that. And then the second one is, I'd like to be able to know what the differences are between the Canadian understanding of palliative care and our understanding. I think if we get a picture of what Canada does, it might give us a little bit different perspective on what we're doing. So the death, illness issue, and then the Canadian
Sure.
issue.
I think the death illness issue, maybe one way I could answer that is to say that as physicians, we've simplified things more than maybe I think they should be. We've taken the philosophy out of it, and we don't talk in terms of illness. We talk in terms of disease, and those are two very different things. Illness includes the impact it has on your life. Illness and health are very different than disease, and either disease-free or treated disease. And that's part of the change that happened, I think, in the middle part of the century. Doctors used to treat illness and work toward health. What doctors became is technicians. And a disease is a biochemical abnormality that if we get the right medicine, we get the right counter-chemistry going, we will erase the disease or cover up the disease or do damage control so the disease, for example, diabetes, we control your blood sugars, all the bad things that diabetes cause don't happen. Those bad things being kidney disease, losing your teeth, infections. But because it's a disease, we don't really take into account the effect of diabetes on your family, the effect of diabetes on your finances. And so I think as doctors look at diseases, it's really hard to go from there to this idea that palliative care has of a person, a whole person. And I think that's really a stumbling block for medicine. And in medical schools, there's classes on this, and people are teaching it. It's 2, 3, sometimes 6 hours, sometimes a little more in some institutions. But it's generally a course that first and second year med students may or may not go to. A lot of times they skip it because there's no test on it. I give the medical ethics lectures for IU, for one of their campuses, for IU Med School, and I usually have about half attendance because it's part of the core curriculum, but it's not a tested part of the core curriculum. So I've got, out of the 20-some people that are supposed to be in my ethics class for, I think it's 8 hours, I have about 6 to 10. So doctors aren't interested in this quote-unquote fluffy stuff. It's all about the disease. And I think as long as that is that way, we're really going to have a hard time processing the idea of illness and bringing in the rest of what it is to be a person, and to look at how illness impacts our life, and when illness starts moving toward a terminal illness, that's just kind of a foreign concept to doctors. Does that make sense? I'm not trying not to answer questions, but it's, like I said, it's a question that you ask a doctor and we'll kind of look at you funny because we're not really speaking the same language. And I think that's the problem. Until we speak the same language, it's going to be hard to go anywhere.
That was very helpful.
Okay. Second question, how is hospice pedicure different in Canada? I'm not really an expert on the Canadian system, but what I do know is that the payment structure is different. Medicare intended for hospice to be used for budgetary reasons for the last 6 months of someone's life, or less. 6 months or less. So they're kind of shooting for 2, 3, 4 months, up to 6 months, kind of is what they want this particular benefit to be available for a patient. Canada has a different approach. They don't have that time limit. If you don't want to focus on curative measures, you want, for example, to be in your own home. If you were to develop a cough and a fever, you don't want to go to the hospital, get x-rays, get CAT scans, get hooked up to IV antibiotics. You want to be at home, maybe go see your doctor, maybe take an antibiotic. If that's not strong enough, it's okay. I'm at the end of my life. Make sure I'm comfortable. If that's not strong enough, it was meant to be the end of my life, and that's just the way it is. And so in Canada, you can elect hospice without having to quote-unquote qualify in sort of the 6-month kind of picture. It's a bit more vague. It's kind of assumed that you'll be in your last couple years of life. As long as you don't want to go the aggressive route, you can continue to get hospice care in your home. So it's much more of the philosophy of palliative care. The Canadian system is completely different with how things are paid for and what's available, who gets what tests, that type of thing. So it's just very different. But they kind of look at us and say, well, that's ridiculous. How do you figure out when somebody's only got 6 months? And those of us who do hospice say, good guesses. So we've really defined hospice as this very narrow window with a lot of constraints. Whereas the Canadian system, it's more about the philosophy and less about money, I guess. The American Academy of Hospice Palliative Medicine Conference this year was actually in Vancouver, Canada, in British Columbia. And it was interesting, the Canadians were constantly razzing the Americans, say, yeah, you guys limit it to 6 months. Yeah, you create all these headaches for yourselves because of this. That's really silly, isn't it? And we kind of sat there and said, wow, it really is.
My question was, if the concept of palliative care was more understood, would that make a difference, if any, in improving the whole healthcare field in terms of jobs? Like, would more jobs be lost in the hospice care, and cost effectiveness and the quality of care?
Jobs are an interesting. The economics of palliative care is very interesting. It saves money, but in this country, if you don't spend money, somebody doesn't get the money, that may affect somebody's job. So, for instance, if you get a palliative care program going and you order half as much chemotherapy, that's going to cut into the oncologist's jobs, that's going to cut into the techs, that's going to cut into the company that makes the chemotherapy. I can tell you it's not going to happen quickly, so the job loss will be probably so slow that it'll just be reabsorbed somewhere else and it probably won't be noticeable. I would just love it if this suddenly took off, but I don't think that's going to happen. When it comes to healthcare quality, most patients are happier when they have a palliative care program involved that helps direct their care. So from a patient standpoint, patients in various studies that are published do say that yes, my quality of care is improved. If you have patients who aren't in a palliative care program at the end of their life, and you have patients that are, and you look at the differences, the patients in the palliative care program tend to think their quality of life is better. Interesting, there was a study published that looked at how long patients lived, and this was a study on a very narrow spectrum of disease, so just patients with a particular condition at a particular stage. It was lung cancer at a particular stage, and they found that the people who were plugged into a palliative care program actually lived longer. And that turned things on their head, because if they lived longer, they actually utilized more resources, so it actually was more expensive in the healthcare system. So the answer is it's really, really complicated. But it does improve patients' perceptions of outcome. It does improve patient satisfaction. And it probably would save a lot of money in this country, which seriously, we need to save money in healthcare. So most of us think it's a good thing. It will have some consequences economically for some folks, however.
How does the insurance work in all this?
Insurance generally doesn't pay for it. That's why it doesn't exist.
Nothing from palliative care?
They don't typically pay for palliative care, and that's part of the issue. As a physician, I can bill for physician services. So if I see someone in the hospital as a palliative care doctor, just like a cardiologist sees them as a cardiologist, I can bill. The reimbursement structure is set up for very short visits. For example, outpatient is set up basically intending the doctor's going to spend about 15 minutes with the patient and then move on to the next one, maybe 10 minutes. Palliative care encounters are much, much longer than that. We're not reimbursed by time, we're reimbursed by those codes. So if I see a patient for 45 minutes, I may be getting the same amount of money as a cardiologist sees, actually I don't, but say a primary care doctor or a not a very high paid specialist. We get the same codes, we get the same amount of money, but he sees like 5 patients in the same amount of time. So what happens is palliative care loses money. To have a physician do that instead of do something else, there's no economic incentive from a payer standpoint, payer being Medicare and insurance. The nursing time involved in this, hospice is mostly nurse-driven. The nursing time is not reimbursed by insurance for palliative care. The social worker time is not reimbursed by insurance or Medicare for palliative care. The chaplain time is not reimbursed. So all these services that we need to make palliative care go are not reimbursed by insurance, not reimbursed by Medicare. So if nobody's paying for it, it's going to be pretty hard to make it happen. Now, there are some things about inpatient care that I can talk to you afterwards about that actually in a hospital you can sort of save money by decreasing the length of time the patient's in there, getting to decisions faster so that somebody doesn't sit in ICU for 3 weeks trying to figure out what to do because nobody bothers to sit down and ask them what do they want to do. There's ways to save money that kind of offset this, but insurance doesn't pay for this. There are some insurance companies now that are contracting with hospice agencies to provide palliative care. For example, in Green Bay, Unity Health actually has worked out contracts with insurance companies. And they say, look, you've got all these chronic patients that are in their last 2 years. They're going to the ER every 2 months, every month. If we go out and see these patients, we'll keep them out of the ER. Will you give us a lump sum of money per patient to follow these patients and keep them out of the ER for you? The insurance company says, that sounds like a good deal. Yeah, we'll give you so much money if you follow that patient. And so now we're bargaining. And you can get insurance sometimes to pay for palliative care that way, but it's on a site-by-site basis. That's Green Bay, one group. So right now it's generally not paid for. Yeah?
I'm just wondering if you could comment on the quality of life of the person and their the rights that they have and the freedom that they have to make choices for themselves about the treatment they receive. Outside of the financial picture.
This is a great, she teed it up for me. That's really what palliative care is all about. In my mind, palliative care is all about patient choices. Unfortunately, palliative care has gotten the reputation of being about death panels, about death. But I think that's because when I go in, sit down with a team and talk to a patient about what's going on, and a patient is at the end of their life, most patients don't want what they realize is futile care that's really not going to be a benefit to them. So I see patient choice as what's driving what palliative care does. When we withdraw a ventilator from a patient, it's because that patient has said, either in person there to me or to their family before they ended up on the ventilator, and their family says, you know, Uncle Joe absolutely would never want to be on a ventilator. He said if he was ever on a ventilator for more than a day, he didn't want to live like that. It's the patient choice that drives pretty much what we do. We've had patients on different palliative care teams I've been on that have wanted very aggressive treatment. So that's what our team has advocated for. And that always flips people out when the palliative care team is advocating not to withdraw a vent. People say, well, you guys are the death squad. You guys are the ones that are supposed to come in and pull plugs. You're like making us keep it plugged in. But that's because, again, it's back to patient choice. It's about the patient's choice. And palliative care, in my opinion, really looks to the patient as the one who is the best able to say what's right for them. As a physician, even before I was doing palliative care, I never wanted to be in the position of telling a patient what the right thing for them was. Patients need help. They need guidance in figuring out the right thing. Medicine's very confusing. But I firmly believe, and most of us in palliative care believe, that the patient is the one that should determine what the right and the wrong thing is for them. They just need a lot of help figuring it out in this very complicated medical system. So in my mind, palliative care is all about the patient choice. At the end of the day, it almost all comes down to patient choice in palliative care. Did that answer it?
Yes, thank you.
Okay. Yes?
You just began to touch on what my question was going to ask. If it's patient choice that's going to determine the level of palliative care, what kind of information, what kind of education are these patients getting relative to outcomes that would result from the various modalities, whether they are continued to be treated or put on just palliative treatment?
Right. Well, and that's where the idea of, there's an idea that's very common, and it's probably because it's harder to grasp what palliative care really is. Palliative care is not sort of a one-or. It's sort of a how do you choose. So it's not I'm choosing chemotherapy or I'm choosing palliative care. Palliative care, we don't want it to be that choice. We want it to be, do you want chemotherapy or not? Do you want radiation or not? Choosing not doesn't mean you're choosing palliative care, because if you're choosing radiation, that's fine with me. I want to make sure you understand why you're choosing it. I want to make sure that, for instance, I want to make sure that when a patient says, oh, I don't want radiation, and I look at the chart and I go, you know, radiation to this tumor in this person's jaw is going to prevent that tumor from eroding through their jaw and getting into their sinuses and causing a lot of necrotic dead tissue, which honestly smells horrible. That's going to mean their family's not going to want to be around them. They're not going to want to go out of their home because they walk in the mall and everybody's looking around for where is the smell. I had a patient like that. That's huge. And so when a patient says, oh, I don't want radiation because they don't understand what radiation therapy could or couldn't do, that's the problem to me, not what they're choosing. So in that sense, I would want to make sure that that patient, maybe for instance, heard from a radiation oncologist, the one that actually knows what will radiation do, what will it not do, to know whether they want that or not. So again, it's all about empowering patients, and I want the patient to have the information to make the decision. And honestly, as a physician, I can kind of tell the generalities of this, but it really comes down to the patient's primary doctor, who knows them better than me, to kind of actually give them the specifics, what you said, what's it going to do, what's it not going to do. It comes down to sometimes seeing a specialist, a radiation oncologist, to actually tell the patient, what's the reality? What are your symptoms going to be with radiation? What are your symptoms going to be if we don't radiate this tumor? So as a palliative care doc, I try to bring in a lot of doctors. I try to bring in specialists. I try to get, patient may not be able to see the radiation oncologist, so I'll call a radiation oncologist and say, this is the tumor I got, this is the size it is. What do I tell this patient? What are the odds you can help them? How much are they going to suffer if they come get radiation? And then we'll try to bring that back to the patient. So it's all about the information.
Thank you. I'd like to have you hold your questions, please, because Lynda has a presentation to make, and I'm sure Dr. Clutter would be able to answer some additional questions after her presentation is done. Thank you.
And there has been, can you hear me? There's been numerous responses that Dr. gave that segues right into my part of the presentation, and that's in regards to education about this, making choices and creating goals for people who are dealing with overwhelming and or sometimes catastrophic health situations. But I don't know how to get this on. Oh, I did. Well, there you go. Palliative care, as described by Doctor and as described by the World Health Organization, the Institute of Medicine, the National Hospice and Palliative Care Organization, and the Hospice and Palliative Nurse Organization, actually is that the medical team strives to improve the quality of life for those people who are facing life-limiting and or life-threatening and end-of-life situations. I mean, that's it in a nutshell from those organizations. My passion to get the information out to nurses regarding palliative care and all the strategies that are used to provide this quality is what led me to develop the Palliative Care Certificate Program for registered nurses. Why just registered nurses? Because First of all, I'm a nurse. Second of all, I was in a college program to get my master's in nursing, and I needed to do a project or a thesis regarding something that I was passionate about, and that is why I developed this program. But more importantly, when I started doing research, I learned that studies have proven that the nurse does spend the most time at the quote-unquote bedside of people during these life-threatening, life-limiting, and/or end-of-life situations. And therefore, I felt that it was a place to start if I could provide more education to nurses, not only in the palliative care field. They are getting the education. They know how to try and afford people quality of life. But it's to all of our nurses that are out there, because all of us are going to, oh, so now it's going to do its thing. It's perfect. All of us are going to come in contact with a dying person, a person with a catastrophic disease, a person with a catastrophic trauma that has happened that has changed their entire life. So palliative care is the provision of the best possible holistic care, as we have been just recently by Dr. shown. It's spiritual, physical, emotional, psychological. Where did I leave out? Thank you. Big social, because you're going to get it in the next picture. Okay. For a life-limiting and life-threatening illness. It's oftentimes not available. It's not available for financial reasons, for the reasons that our medical society in the United States is all about cure. But it should be available based on making choices and providing quality information to people to make decisions so that way their outcomes can be met. Multidisciplinary approach to a multidimensional healthcare crisis. That's my own little spin on it. Now, the social aspect, family aspect, multidiscipline. All disciplines are needed to help out with this catastrophic illness. When this happens to one person, let's just take, this is part of my family. There's some of my grandkids that aren't there because they weren't born when this picture was taken, but so there I am. So if I have a catastrophic illness that happens to me, I just had a minor thing not too long ago, and I was in the hospital for over a day, and the phone in my room rang constantly. I have 7 children, I have 7 in-law children, and I have all these grandchildren. It affected each and every one of them. And I will tell you that it affects them spiritually, it affects a person physically because they're hurting so spiritually, psychologically, and emotionally. So it can create diarrhea, it can get somebody a migraine, because if you have a part of your physical body that's kind of a weak spot anyway, and that's how you deal with stress, you're going to have some physical. You're going to visibly see the physical effects of a life-threatening catastrophic situation. I just thought I'd throw the picture in there, but it's not going away. Oh. The history of palliative care education, actually, when I looked this up, it begins with Florence Nightingale, when she tried to educate the physicians and fellow nurses that were working in the field during the Crimean War to improve the care of those soldiers who were suffering because of catastrophic illnesses, maybe injuries, and what was going on because of the poor sanitation conditions and the inability to get to so many needs. There was much suffering that was going on. So she was trying to educate about how to reduce suffering and improve the quality of the individual, even though they knew this individual was not going to live. began there, and as so nicely demonstrated a few minutes ago, or maybe a half hour ago, about Dame Cicely Saunders, who definitely went further, and she did open the first hospice and did educate, and it was a life goal of hers to educate. And just to let you know, Sister Ann Jude, who's here with us today, and Sister Mary Agrita, who has since died, in 1978 went to London, and I thought it was more than 2 weeks, but I was just informed today, for 2 weeks, practically didn't sleep for the entire 2 weeks while they were educated on how to develop and set up a hospice. They came back and developed the first hospice in the state of Wisconsin in 1979. 78, I'm sorry, okay? So that's the history, and they've been educating and working to provide quality care and help people make choices since then. So one of the questions that I had to answer was, have schools of nursing answered the World Health Organization, the Institute of Medicine, and the American Academy of Colleges of Nursing recommendation to improve palliative care education? We have to educate. And I found that they were not. Textbooks that, studies have been done and research textbooks that are in our schools of nursing, and as Dr. Clutter said, even in medical textbooks, there's little, if any, in some textbooks that refer to all of the aspects of palliative care, especially end-of-life hospice care. So the significance of palliative care education then is an opportunity for the registered nurse and other disciplines to gain knowledge, so therefore they could help people and the institution to provide proper education about tried and true methods that would help people to make choices for good outcomes. Also, developing a palliative care education course for nurses certainly represented Marian University's vision to transform lives through academic excellence, innovation, and leadership. You know, a person can't be responsible for providing something or doing something if they don't know how to do it. And that's how you have to look at this education piece. The other political issues regarding reimbursement and where we are in our healthcare society and medical science advances certainly come into play, but still you have to have the knowledge. I did a needs assessment, and this is down and dirty. What I did, I had to discern the number and quality of palliative care education programs in the schools of nursing in Wisconsin. I screened the 13 colleges of nurses in the state of Wisconsin, and not one of them had a formalized, structured palliative education program for nurses. As a matter of fact, I screened throughout the United States, and there was, I think, at the time, only 18 programs that were related to nursing education and palliative care. Okay. I discerned why palliative care education programs are rare in the United States and Wisconsin, and I believe we've just gone through that. Dr. Clutter certainly alluded to it. I've alluded to it. Our medical science, every aspect of what we learn is cure, cure, treat, treat. Keep going, keep treating all possible treatments. Like Dr. Clutter said, you don't have enough of a lifetime to get everything that's out there that to deal with your disease or your problem. Identify the needs and priorities for palliative care education program in the School of Nursing at Marian University, and that goes without saying, and discern the priority concerns about palliative care in the local community. I did the ideas about the concerns of palliative care in the local community by doing I did a SWOT analysis, and I interviewed 4, and wound up being just 4 people, from the community, and it turns out that they felt the same way as what's in all of our textbooks. We definitely need it. We need people to know how to make choices. We need qualified nurses and medical people and medical disciplines to help patients to make the right choices or to make choices. And palliative care itself was definitely needed in our community. That's what that came out as. More than all four of them said it's about time our community was educated on palliative and end-of-life hospice care. Okay. Objectives: identify the audiences for the program, and I identified, of course, more than our registered nurses, and this college has programs for social workers and educators, spiritual advisors, theology, and those all are disciplines that come very, very, as Dr. showed you, they are a very important piece of contribution to helping people make choices during this time. However, I had to start somewhere, and I started with the nurses because I'm a nurse. Design a curriculum and mode of delivery of the program, draft a budget for the marketing of the program, and identify methods for program evaluation. I used conceptual frameworks. Actually, I utilized the 8 domains of palliative care that was developed by the National Consensus Project. The National Consensus Project, and I always have to look, I'm sorry, was the National Quality Forum. It was, I have it written down, major groups of organizations, the American Hospice and Palliative Nurse Association, the, if you get it, I'm sorry, as I'm looking, I'll have it written down if you please mind. So I used the 8 domains of palliative care that they identified because with each of the domains, there is evidence-based practice guidelines that we can utilize to teach and to be sure that as we approach patients to help them make these choices, there's been tried and true procedures and guidelines to help the outcomes be successful. The 8 domains start with structure and process of care, physical aspects of care, psychological and psychiatric aspects of care, social aspects of care, the spiritual, religious, and existential aspects of care, cultural aspects of care, care of the imminently dying patient, ethical and legal aspects of care, which we even touched upon today. I structured the palliative care education program in the United States, like I said, were rare, and the cause of the problem is because of cure and control of disease. So the needs were that registered nurses, professors, and instruction equipment and text were discerned as being needs. I needed to market it, budget it, inclusion Marian's postgraduate curriculum, because my original program was for advanced practice nurses, but then I adjusted it to registered nurses. Registered nurses, whether they were graduates of a 2-year program, 3-year program like I was in the beginning, or a baccalaureate program. The existing concerns were all taken into consideration. Cost of credits, and these are the concerns that would put barriers to the course. The cost of the credits, the time constraints for classroom attendance, limited institutions for the advanced practice nurse or RN to acquire the necessary practicum hours if they needed it to eventually go on to get national board certification in palliative care. Perceptions. The strengths were that education is necessary so we can be held accountable. Our weaknesses are that we're all about cure. Our opportunities was it was an opportunity to help to provide education and then branch out into educating other disciplines and incorporating other disciplines in the education. And our threats were the normal threats. Cost, as I've spoken about many of them. Also, the advances in medicine that are so toward cure as opposed to allowing people to make choices. So I needed to provide an organized and disseminated palliative care education that fulfills the recommendations of the World Health Organization, the Hospice and Palliative Nurse Association, the American Academy of Colleges of Nursing, and help to fulfill the mission statement of Marian University. So I did. I designed the program, and I designed it, and the goal of the program is to provide the student with this organized and disseminated knowledge of experts in the palliative care field, utilizing the proven practices identified by each of those 8 domains. Marian University then created a certificate program, and a certificate was awarded. And a certificate, you had to understand, a certificate was different than national certification. It was a certificate that said that you completed the program. As Dr. said, there's all domains of a person, there's all dimensions of a person. To try and sum up and teach about choices in each one of those areas in just 8 hours is very, very difficult. So I broke this down into 3 separate terms, 3 3-credit terms, and over 11 weeks, it's actually over 15 weeks. I've got it over 15 weeks. Each 3-credit course is 5 weeks long. It's an online learning activity. We do a hybrid. We meet in the beginning of the course and towards the end of the course, and the rest is online using the Marian Online. It elaborates, replaces, and reinforces and complements face-to-face teaching. And there is some seat time, as I said, in the beginning and at the end of the course. The term 1 is parts of the domains that structure and process of palliative care, spiritual, religious, and existential aspects of palliative care, ethics, and legal aspects of palliative care. I'm here to tell you that there are some nurses who have completed term 1. It was a rewarding experience for all of us, including me. I mean, you learn, and you learn, and you learn. It was very, very exciting to do that. You have to complete term 1 before you can go to psychological and psychiatric aspects of palliative care, social issues of the palliative care experience, cultural and aspects of palliative care. And then term 3 is physical aspects of care, pain and symptom management, care of the imminently dying. More of the physical aspect, but you have to have all that other education before you get to term 3 because it all is holistic care. The outcome of this was we did add this evidence-based practices of palliative care for the practicing nurse, RN, to help improve care for patients and families living with life-threatening limiting situations, and it empowers the RN to be a leader, mentor, educator, and collaborator. The program evaluation at the end of the program, there's pre-course goals. A lot of the program, the beginning program, we talk about how to develop goals and how to get outcomes. And so the nurse develops their own goals in the beginning. During the course, we take course attendance online. I can do that online, as you all know. And after each course completion, the nurse then evaluates if they completed their goals that they set, plus the objectives of the course. In conclusion, this course was a solution to the minimal palliative care education crisis for the RN and the development of programs such as by developing this program. The information in this presentation provided Marian University with the necessary tools to present the program within our curriculum and in the course identifies Marian University as Wisconsin's first university to offer a palliative care certificate program for the registered nurse. What really pushed me, I've been dealing with end-of-life situations all my registered nurse career. This is a picture of my dad, 2002. This was 11 months before he died. Talk about a palliative care situation. There's just some of my kids. We all flew to New Jersey when we were told that, he called us up and said he was probably going to die. So we all ran out there and did our palliative care thing. We gave him support. It took him 11 months. So a doctor said, there is a proven, he made the decision, no more of this. He had COPD. No more of this pushing. I want to live my life. And what I tell my patients when I have that opportunity to talk to my patients is, it's a matter of the disease has done its course. It's kind of won the battle. Now it's time to just concentrate and take care of you. And you are the one who's in charge of the choices that are going to be made. And that's part of the education that I present to the nurses who take this course. Thanks.
Thank you, Lynda. Are there questions, please? Just a second.
I'm loud. Lynda, you said that the nurses you had a first group going through term 1.
I did.
Are they ready for term 3? 2, I mean?
They are. However, term 2 has been presented, but they were not in a part of their life where they could, number 1, afford to do term 2, and number 2, which is not very expensive. If you take it for credit, it's the normal credits that course per credit. You take it for continued education units, which, by the way, was 36 that I got from the Wisconsin Nurse Association and the ANH. It's $700 for the course, and they just weren't ready to take it. So we re-offered term 1, and it will be re-offered again either in the summer or in the fall semester.
Thank you.
Sure.
Are there any additional questions for Dr. Clutter? Hearing none, I would like to congratulate and really thank Lynda Fields and Dr. Clutter for a very enlightening presentation.